and then I am just going to remove all fills. And actually, when I place my fast handpiece onto this mesial filling, it just flicks off straight away. And then what I want to show here, and this is a bit of an exclusive here, I want to talk to you about the process of what we say to a patient when we know we're not getting to length. And so it's a difficult conversation, isn't it? Recognise that the patient understood it all because of the consenting process. So hello, welcome to this week's Friday clinical case. And this is an interesting case. This is how to manage a patient or a case where you can't quite get to length. And it's always quite a difficult conversation to have with a patient, mainly because we know that if we don't clean the whole complete length of a root canal, then we know that there's space remaining and bacteria can remain, and this can be a cause of failure. However, there's kind of a bit of a catch-22, isn't there? Because we can say to the patient, well, we can filter as far as we can get, or we can just extract the tooth, or of course we could refer to another colleague. But it's a really, really difficult situation. It's also a case of restorability as well. So you'll notice that I make the wrong decision at first about the restorability of this tooth, and in fact, as the situation develops, I change my mind. And this is really what I want to say about all of these videos, essentially, is that this is an unfiltered look at how I practice. So, a lot of people who have these channels and these YouTube videos and Instagram, whatever, is that, I suppose, in a way, a lot of these people are putting up their very, very, very best cases. In my case, I just like to put up the cases that have the best educational value, and if that sometimes makes me look like a bit of an idiot, I don't mind at all. So I like to just show you an unfiltered way of how I practice, and really I'd like to think that this is how most people practice. You go into practice, you have good intentions, things change, you make the wrong decisions, and as long as you correct your course, shall we say, that's probably the best way. So before we get in the case, because I want to show you the periapical radiograph of this tooth, I want to say that over 50% of the people who watch these videos are non-subscribers. So if you're not a subscriber, if you could just do one thing for me. It's quick, it's easy, and it's free, and it's just hit that subscribe button and also the notification button as well. If you hit the subscribe and notification button, it pushes the channel along. It makes me want to do more of these videos each week. We've also got a membership program. It's run by YouTube. We've got a link in the description below. You get early access to content. So we usually work about 3 or 4 weeks ahead with these types of videos. You get to see them early. And also we've got exclusive content. We've got a fantastic endodontic access video. And also we've got the part 2 of our newly qualified dentist survival guide. So we'll look at the case. So we've got an upper right 6 here, and clearly this tooth had suffered secondary decay or a leaking restoration where it's become decayed underneath, and then this has obviously affected the pulp chamber. And when we look at this tooth, we can see that it's a long tooth, and also the canals are quite calcified. So when we are doing our consent with this patient, of course we're going to talk to them about risks of failure and all of the really, really common risks. But what I want to do is I want to tailor the consent process specifically to this patient. And what I'm going to say to the patient is, I know that this tooth is restorable. So I'm going to be talking about not being able to get to length and explaining that. I'm going to talk about file fracture, and overall, this is the key to this whole video. And if you just pause this video now and reflected on what you're going to learn from this, well, you're going to learn essentially consent is key, because if you tell a patient before something untoward happens, well, then you've told them, they understand, and they've taken taking the responsibility of that on. But if you tell them, but if you don't tell them and it happens, then it sounds like an excuse, doesn't it? So let's get into the case. So the first things first, of course, we're going to make sure we are going to place our rubber dam. And in this case, I'm just going to do single isolation because I think that I am going to just remove the composite and also be able to restore this adequately. You know, in hindsight, that's not going to happen here because of the mesial mesial box. But nevertheless, I accessed the tooth, and I've got a new microscope. I've got the OMS 3000 Pro by Zumax, and it's got this fluorescence mode. And this fluorescence mode shows up all of the restorations, and also it shows up decay. So I'm just having a little feel around because I feel like the filling in this is pretty good colour match, and I don't want to remove too much tooth tissue, but we do drill a little bit further down. We breach the pulp chamber, so we're going to just do a bit more refinement, bit of cleaning up. Again, remember at this point I'm going to keep the restoration wrongly, and now I can see there's a bit of decay on the mesibuccal here, so I'm just going to use my slow handpiece just to remove the lot of this decay here. And what I do notice is that there's a significant amount of decay, and again, hindsight, I can see on the X-ray, but in this case, I'm thinking like the decay is relatively deep here, and I'm thinking that actually what I do need to do is I need to put a proper restoration in this, and then obviously when I do this my investigation with my handpiece distally, again there's a bit of decay. So to make sure I put a proper restoration on this tooth, I'm going to multi-isolate the tooth, and then I'm just going to remove all fills. And actually when I place my fast handpiece onto this mesial filling, it just flicks off straight away. So we know that it should just be removed. And then I'm going to use the fluorescence mode again. You can see there's a bit of decay mesily. And then you see this real strong red fluorescence where the pulp chamber is. And there's like quite a lot of organic material down there. And then again, it's just a very sort of careful, sort of judicious removal of all of the filling material and all of the decay. I like to remove all the decay just to make sure the chamber's nice and clean, and straight away I can see the MB2, so that's a really good sign. We can see this kind of suggestion there's an MB2. It transpires that it's not as easy as and large as an MB2 as we'd see here, but nevertheless we find the MB2, and I'm going to use a diamond tipped low energy ultrasonic here just to remove some of the excess, let's call it tertiary dentin or secondary dentin at the base of the cavity. And what I want to do is I want to obviously expose the MB2. I'm not going to be shaping it just yet, but I want to expose the MB2, and also I want to just refine the pulp chamber floor. Sometimes you know, when you've got this kind of excess dentin at the base of the pulp chamber floor and you start shaping and a little fragment falls off, there's a risk that it goes down one of the canals and then you're in trouble there. So I want to make sure the pulp chamber floor and the pulp chamber itself is nice and clean. And of course, when we give it a clean out with our hygiene ultrasonics, we can see the pulp chamber floor looks really nice and clean here. And I know where all the canal orifices are. So straight away, I'm going to just make sure I do a bit of irrigation. And then what I notice is the rubber dam isn't as tight as I'd like, and the patient can taste a little tiny bit of the bleach that I've used. So I just make sure I really fully irrigate the mouth. And, you know, again, I've been slightly lazy here. Really, I just need to place a restoration on this tooth. I personally think that you know, it's all about time with patients, isn't it? You know, I do book a significant amount of time for people, but what I don't want to do is I don't want to spend too much time on something that I know can be done at a later date, just in case, of course, you know, we need the extra time to try and get down the canal orifices. And you might say, well, you just book the patient in, and that's all well and good. You know, you could just book the patient back in. You know, patients have real lives, you know, so, and also you might think to yourself, well, a patient is probably terrified to come to the dentist, so they're expecting this appointment to be done in one. And of course, I understand that if you need to book a patient back in, you have to book them in, but you just need to use your common sense sometimes. And a patient, it might be a case of, if you get 2 hours with a patient and you manage to, clean and shape the tooth and get it all sorted, then that's a result for a patient, and they don't have to take book time off work. And so it's not so cut and dry as like, I'll just book another appointment. You just got to use your common sense and read between the lines slightly. And to restore this tooth, what I'm going to use is a matrix band, squiveling band. I'm going to use these Palladent wedges, and I'm just going to try and adapt the band to the contact point. Sometimes these squiveling matrix bands aren't great for adaptation, but in this case I noticed the distal aspect of this box, the adaptation wasn't perfect, so I just used an extra wedge. And once we've etched, we're going to use, this is iBond, and then I'm going to use a little bit of flow to adapt the composite filling into the margins. And then you can see here that I'm using some composite. This is heated, and you could argue maybe I've placed a little bit too much composite in this. I haven't laid this too well, and maybe is C factor going to be an issue here, but overall, I'm relatively happy. The problem, of course, of placing too much composite is that when it sets, it shrinks, and then that can affect the marginal adaptation to the contact point to the adjacent tooth. But overall, you can see that I've placed the composite filling. The contact point's not too bad, and I'm ready to take my first working length check, and this is going to be with the palatal. I feel like the tooth is very, very large on the X-ray, so I'm just using an extra long 31 length. 31 millimeter length K file, but this goes to length pretty easy, and in fact I didn't really need this extra long K file in this case, because when we remove the file and we do our working length check, we can see that actually the zero reading on the palatal canal is 23 millimeters. And just going to use my same protocol and use a size 15 glide path file at 0 at the 23 millimeters, and then I'm just going to use a size 25 straight up to the 25 at 22.5 millimeters, and then just going to shape it really nice and easy, and so far so good. So, I've got to length on the palatal. I'm thinking, I've got a good feeling about this. I'm going to get to length on all these canals. And of course, given the thumbnail and the description, we know I don't. And then I'm going to now attempt my negotiation in the DB canal. Again, I'm going to use that size 31 file because I feel like the root is quite long. But I hook this up to the apex locator, and I'm not quite getting 0. And the furthest point reached is about 21.5 millimeters in the DB. And I really am getting severe resistance here. So what I'm going to do is I'm going to do this kind of coronal shaping. I'm going to get a glide path file up to 21 millimeters. So this is 0.5 millimeters away from the furthest point reached. I'm going to open up that canal space, and I'm going to use the size 25 as well, at about maybe 20 millimeters. And then I feel like maybe the 31 was a bit too long and a bit too flexible, and I use a shorter 8 now. And when I hook this up to the apex locator, still I'm not getting to length. So what I'm going to do is I'm going to move over to the MB. I'm going to irrigate the DB, and hopefully this irrigation kind of soaks into the DB and opens things up. And again, I hook up the apex locator to the mesiobuccal canal, and again, it's not getting 0 either. So super frustrating. I've got 2 canals where I'm not getting to length quite easily. The furthest point reach is 21 millimeters, this mesiobuccal canal. So I'm going to use the same protocol as I did before. I'm going to open up the canal orifice, and I'm going to use a glide path file. It's a bit shorter than the actual furthest point reached. Give it a little bit of irrigation. Again, I'm using size 25 to open up the canal orifice. And then this time, when I place a size 8D finder into the mesiobuccal canal, I notice now that it's reaching further. And in fact, this kind of coronal opening is actually has ensured that this file now is reaching 0. And when I hook it up to the apex locator, the file is past 0. And of course, to gain an accurate working length, I'm going to make sure the file's past 0, and we're going to just slightly back up the file until you reach that 0 reading. And that's a much more accurate reading, say, as if you just place it in and get to 0 and not push it out. So It's a little bit delicate because it is quite calcified, but when we pull out the 8D finder, we get the correct working length. We're going to shape it to a 15. We're also going to shape it with a size 20 before we shape it with a size 25, mainly because the jump from a size 15 to a 25 is actually quite quite a large jump. So what I don't want to do is, I was struggling to get the length with and the MB with my size 8D finder originally, so going with a size 25 without stepping up nicely, there's a real risk that you ledge. So once we've shaped the MB, I'm going to just place my ham file back in to the DB, and again it hasn't worked at all, and I'm actually using a stiffer file here. I'm using a C+ file. So my next step here is just to soak the canal orifice with EDTA, and you know, I don't know what the evidence is for soaking the DB canal with EDTA, but I suppose in a way, if we can't get to length, having it soaking with EDTA and opening up all the canal orifices isn't a bad thing. And actually, if you leave the EDTA and let it soak for a very, very long time, I would say more often than not, what happens is you go off for another canal orifice, and then when you reach down there, it opens up. So I think this EDTA soaking protocol's a pretty good way of opening up calcified canals. So again, so we're going to let the EDTA soak into the DB. We're now going to try and negotiate down the MB2. And in fact, when we removed that kind of extra denting at the bottom of the pulp chamber floor, it kind of removed where that kind of MB2 canal orifice was. But nevertheless, it is still there. And I'm just going to use a size 8 D finder just to try and negotiate this MB2, and it is really severely calcified, but I know for a fact it is definitely there. So a lot of the times, if I can't negotiate down the DB, I'm just going to give it a bit of a clean up with my high energy ultrasonics, and I like to use a stiffer file. And all the way through this case, I've talked about stiffer files. So the shorter a file is and the thicker it is, the stiffer it is. And if you're struggling to get to length, if you've got a stiffer file, it's more likely to push to length. But in this case, again, I'm not reaching down the MB2. I know it's definitely got an MB2. So what I am going to do here is something super, super risky, and I wouldn't suggest doing it unless you're very experienced, is that I use a glide path file without using a ham file to create a glide path before, and I'm not pushing this to length. And what this does is that it actually cuts the MB2 pretty well. But what I do is I'd like to remove the glide path file just to check to see if it's unwinding, because if it is unwinding, there's a fair risk that the file breaks. So once we've opened up the MB2 canal orifice with the glide path file, the rotary file, I notice now that I'm getting a little bit further, but not too much further. So I'm having a little feel around. I'm not pushing it too hard. I'm just going to adjust the stopper. And when we pull it out, we can see there's a bit of a significant bend in this. And then when we measure how far we've reached about 15 millimeters. So I'm going to open up the MB2 with the original glide path file at 15 millimeters. And again, this is that kind of protocol of opening up the coronal aspect of this canal. And what you don't notice here is this is a new file, because I feel like this rotary file is been down the DB, it's been down the MB, it's been down the platal. It's also had a significant amount of action in the MB2 without a glide path file. So it costs nothing just to get another file. Well, it costs a little bit, but it's better than fraction of file. And then I'm going to use a size 20 at about the same length. And again, it's this kind of concept of opening up the canal orifices. And what I don't do now is I don't continue to shape this MB2. I want to move back to the DB, and I'm going to make sure that the MB2 is now soaking in lots of sodium hypochlorite. So we move back over to the DB. I'm going to use a size 8D finder in this case, and I'm just having a really, really gentle feel around. And what I didn't show on this one is I made a little bend at the end, and I'm just having a little feel around, like a kind of a watch winding motion, just to see if I can get past this kind of stop that we've experienced earlier on in the appointment. We hook it up to the apex locator again. We're kind of at the same level, a little bit frustrating, and I'm just having a little feel around. I'm not pushing this really hard. I'm just having a little feel around in 365 degree motions. I'm just obviously removing the ham file, putting the bend back in, having a little feel around. And kind of the furthest point we've reached here is 21.5 millimeters. So I'm going to use a Tooth Saver 1403 file here. For some reason, I like to get these out because I feel like these have got a really good cutting efficiency and they're very strong. I'm going to open it up again with the size 25. And now I'm going to get a stiffer C+ file. This is a size 10. I'm going to measure it at 22 and I'm going to make a very, very small bend at the end. And again, when we talked about stiffer files, they're more likely to push to length rather than sort of bend in the file. And we're having a little feel around here. And I'm just getting absolutely nowhere with this file. And what I don't want to do is, you can see here that I'm at 22 millimeters. And what I don't want to do is, I believe these C+ files, I could be wrong, that they're end cutting. I don't want to create a ledge or worse, a perforation. So we're having a little feel around now with this size, with this size 8. And it's at this point I'm thinking to myself, I'm not getting to the end. This is tough for me because I obviously I've got pride in my work. I'm thinking to myself now, what's the next step? And the next step really essentially is talk to the patient. So we're going to just park that problem just for a moment, give it a little bit of irrigation. I'm going to move back over to the MB2. I'm going to get it my size 8D finder, and we're going to try and see if the MB2 in fact has its own canal or it joins. And again, when we pull this size 8D finder, we have that kind of bend in it, which indicates confluence with the MB1. And then I'm going to try with a size 6 C+ file. Again, these are stiffer. And again, I'm going to try and see if this goes to length. You can see there's a definite join here. That kind of bend is where it joins onto the MB2. So just to check this confluence, what I'm going to do is I'm going to get a master cone in the MB1. I'm going to place this to the working length, and then going to get my size 8D finder, put this into the MB2 canal orifice. It's a little bit stiff, a little bit difficult, and we'll just have a little watch wind. I can feel that kind of sponginess in the GP cone. And then when we pull the GP cone out, we can see that there's a definitive mark here on the GP cone. And when we measure it, we can see that it joins at about 16 millimeters. So I'm going to shape this at 15 millimeters. I don't want to go too close. I don't want this size 20 rotary file to go around that bend because I don't want to fracture this file. And we know that, if we give it a nice clean, it's going to clean all of the canal orifices. And then we're ready for our cone fit radiograph. And when we take the cone fit radiograph, we can see that the palatal is to length, the MB is to length. We can see the join there with the MB2. And obviously we can see the DB is short, although it's kind of near to where we're kind of at the end of the canal, but it's obviously short. And then what I want to show here, and this is a bit of an exclusive here, I want to talk to you about the process of what we say to a patient when we know we're not getting to length. And ideally, what I do is I take the periapical radiograph you can see here, and then what I do is I place the rubber dam on, and then we have a chin wag while the patient's in a chair about what we're going to do. So listen now. I've managed to get to the end on 3 of them.
Yeah, okay.
And on one of them, so we measure the roots, you see, and they're all around 20 millimeters in length. Okay. That's what that beeping sound was. Mm-hmm. And on one of them, I'm about 21, but it's not showing them at the end. Okay. So it's kind of, we're in the vicinity. Okay. So, I've spent a significant amount of time trying to get past, to get to the end. And I've done all my little tricks and everything else. I've still not got to the end. Now, what I could do is I could just keep going and going and going. Okay. We spend another hour in the chair. You come back and I look around. That's the one option. Mm-hmm. Problem with that, of course, is it's extra time. Also, it puts stresses on my instruments. And if I break one of the instruments inside your teeth, that significantly lowers the prognosis of the tooth. The second option is that we just filter as far as we can get. I think that's the best option for you. We fill it, and then, you know, we were talking about that sealer we use that tries and gets into the little nooks and crannies. I'm going to try and do that today.
Okay.
So as long as you're happy for me to do that, I'm happy to do that, with the understanding.
What do you think?
Perfect. The third option is that you see somebody else.
Okay.
But if you see somebody else, you know, who's to say they're going to get to the end as well? So I have to give you all the options. But you know, what I want, I just think we should just fill it to as far as we can get and see how we get on.
Okay.
I think that's your best option. If it doesn't work, then there are other options, okay? They're not pretty, but there's definitely more options, okay? You know, we're talking about the surgery thing and stuff. So I think you might be okay. So it's a difficult conversation, isn't it? Recognise that the patient understood it all because of the consenting process. So when we saw originally, we drew pictures, we explained everything, and also, you know, before we started the appointment today, she understood. Another thing I wanted to mention is that I did forget at the start, is that the amount of times I can't get to length on canals, and when I have done this kind of hydraulic condensation of the sealer, what that's done is it is flowed into that space, that kind of very, very tight bend. We get it a lot on distals of lower sixes. So at this point, I'm going to try and hydraulically condense the sealer into this kind of you know, this tight kind of bend or calcification. It transpires that it doesn't do that, but overall, you know, it's not ideal. It's not the perfect treatment, but the patient understands. They've taken the responsibility on, and they have made an informed decision. I can't stress that enough. So we're just ready to obturate now. I'm going to remove and disinfect all of the GP cones. And we're going to do our final irrigation protocol, which is sodium hypochlorite activated, EDTA 17% activated, and then again sodium hypochlorite activated, and I'm using full 5% now. You know, and some people in the US might say that's not strong enough. I was using 2% for a very long time, mainly for safety reasons. But, you know, once we've irrigated everything out, we're ready to dry with our paper points. I'm using these sterile Wave 1 Gold paper points, despite using high flex. And then we're ready to do our obturation. And, you know, the palatal canal is massive. So what I do want to do is I just want to make sure I fill this palatal canal really, really fully. And I can do this quite accurately, mainly because I'm using high magnification. And I'm just going to use a hand file just to introduce the bioceramic sealer into the palatal canal. And then I am using a GP cone just to very, very gently push this down. You notice it's bobbing up a little bit. Don't ram it down. You don't want to get too much extrusion. And I'm just going to use a heated plugger here just to remove the excess. And sometimes with these very, very large palatal canals, you need to add a few little accessory cones, mainly because when you come to condense the obturation down with these Mach 2 pluggers, we can see that sometimes the Mach 2 plugger just slips and then causes problems. So overall, the obturation for the rest of the other canals is pretty straightforward. And then obviously the sealer just gets everywhere and you can't really see really, really well. So what I do is I do a kind of a removal of the excess GP and make sure I condense it down a little bit, and then I use an ultrasonic just to remove all the sealer, and then I just tidy it up. So this is, when I say tidy up, I'm removing some of the GP and just making sure the GP sits slightly below the canal orifice, and then we're ready essentially for our final restoration. And when we can see here, we can see we've got a nice little sealer puff with on the palatal and on the MB. Should we be trying to get a sealer puff? Maybe not. And then when we look at the DB, again, you know, it is short, but actually we've gained a little bit extra length on this. And overall, given the circumstances, I think this was the correct course of action. And, you know, I suppose in a way, when I first practiced, I was a little bit of a perfectionist, and when I didn't get to length, I used to beat myself up quite significantly about this. But and this might resonate with you. You might be someone who beats themselves up about things, but overall, the patient was informed. Overall, teeth are incredibly difficult, and this is a really, really difficult procedure. Nothing is guaranteed, so you just need to bear that in mind when we think about these types of cases. And overall, thanks for watching. Again, if you haven't subscribed, please subscribe. There's a membership program, got all loads of exclusive content, and I'll see you in the next video next week.